Hoy tenemos el gusto de contar con la presencia del doctor Marc Benninga. El doctor es un reconocido gastroenterólogo pediatra del Children's Hospital, es un referente para todos los que hacemos motilidad, y es su primera vez en Argentina, y como ya le dijimos, esperemos que no sea la última. Intentamos que lo pasara bien, ojalá lo hayamos logrado y que bueno, tenga ganas de visitarnos otra vez. Y también nos acompaña el doctor Peter Manuel, que es un gastroenterólogo pediatra del Hospital de Niños de Filadelfia, que compartió con nosotros estos días de congreso. Quiso venir a conocer este hospital donde se formó su compañero, el doctor Pablo Laje, que muchos de ustedes conocen, y bueno, iba a estar compartiendo un ratito con nosotros. Así que muchas gracias Marc, muchas gracias Peter y a todos ustedes. Bueno, vamos a dar comienzo a la conferencia del doctor Benninga, que nos va a hablar de irrigaciones transanales. Marc?
So let's start. No problema. Okay, so I will give you an update on constipation in children, but first I like to tell a little bit of my own country. Have you been in Holland? Somebody? Nobody? No, a few. So, where were you?
In Amsterdam.
Okay, I come back to you. So next slide, please. So this is Holland, and I think it's as big as Buenos Aires. Well, a little bigger, but we have like 17 million people living in Holland. And Amsterdam indeed is the capital city. Next slide, please. And Holland is famous for their flowers. And typical, if you go to Holland, then you should go in this time of year, because now it's spring. So for you, it's autumn. So I see all the leaflets on the leaves lying in the streets. But this is Holland at its most beautiful. So we have not many blue skies like you in Argentina, but we have these windmills and the tulips. And this is real. So from April to May, if you go to these areas, you will find all these beautiful flowers, and all the foreigners are like this in between the tulips, making the most beautiful pictures. And the famous location is Keukenhof. Next slide, please. And we are also famous for cheese. You know, this is Alkmaar, which is a little city near Amsterdam, but Holland is famous for Gouda cheese, and we pronounce it as Gouda. Terrible language, Holland. This next slide, please. And this is the city I live. I really love the city. I have to admit, Buenos Aires is beautiful, but Amsterdam is also a very beautiful place. And if you look at these houses, these are the canals. So if you go there, please take a boat and go through the canals. And then you see all these different houses. And if you look at the top of the houses, the rooftops, they're all different. And all these houses are more than 400 or 500 years old. And so you think this is one house, but most of the floors belong to somebody else. So it's very rare to have one house by a family, okay? And it's very small. So if you have to carry a piano inside the house, you really have trouble, because you have to open the windows because it's so narrow. Okay, next slide. And of course, we are all riding our bikes. So if you are in the Netherlands, everybody is on the bike. Here in Argentina, it's fine. In Buenos Aires, you see some people on the bike. But for instance, I ride my bike every day to the hospital, which is half an hour. Back and forth, 1 hour, something, because I can then eat a little bit of meat. But otherwise, it would be terrible. But we love our bikes. Even if it's raining or windy, we take the bike because it's very difficult to ride our bike in the city. Yes, next slide. This is Amsterdam by night. Very, very dangerous, because everybody is smoking pot. That's what the foreigners think. It's not true, but that's why Amsterdam is also famous for, because you can get hashish for free. Okay, so you smell in the streets. If you're on your bike, you get high yourself. So next slide. Then you probably don't know the gentleman on the right, but you might recognize this painting. And this is one of the most famous paintings in the world. It's called The Night Watch. It was painted by Rembrandt. And this is in our most beautiful museum, and it's a very large painting. And again, if you go to Amsterdam, you should go and see this painting. It's amazing. Okay, next slide. Then, of course, I have to tell a little bit of the rivalry of Argentina and Holland. Isn't it true? Because you only think about the guy, what's his name? Messi. Like that. So I give you a little bit of the history of soccer between the Netherlands and Argentina, because I don't know, I'm very much into sports, so I like it very much. So this was my all-time hero. Oscar doesn't know it, he thought he was a ballet dancer. This is 1974, Johan Cruyff. I saw many of his games. Went to the stadium. When he died, there was a funeral in the stadium. My son and myself, like, you go to River Plate, I go to Ajax. This was all our all-time hero. So this was 74. 4-0, okay. Then 78, next slide. Very difficult time because Holland didn't like, the government didn't like Holland to go to Argentina at that time. You remember the times. And it was 1-0 after 90 minutes. Mario Kempes. I've been there. Don't tell me. So this was 78. But Johan Cruyff didn't participate because he didn't like to go to Argentina at that time. So it was not so very nice. Next slide was 98. This was the US. This was one of the most beautiful goals ever scored in the World Cup. 80-meter pass to Bergkamp, last minute. Okay, but now I stop. No, I don't. Next slide. So then the Messi area came along, and as you can see, 0-0, 0-0, 2-0. But we lost all the matches on penalties. Okay, and Messi is famous for this. So I now do it to you. Okay, next slide. We have another common rivalry, and that's in female hockey. As you know, because Holland is a very good country in hockey. You recognize Realizada Aymar. And next to her is one of the most famous Dutch hockey players. I think she won 3 gold medals in the Olympics, on the left. And the Dutch players love it to go to Argentina because there's rivalry, there's a lot of spectators who are watching the games, everything is nice. So the last relationship between Argentina and Holland is
Maxima.
slide, please. There she is. So this is also a famous picture for the Netherlands. Almost long ago, the guy next to her was very young at that time. He's the king, Willem-Alexander. Some people like him, some people don't, but everybody loves Maxima.
Yes, of course.
Well, I don't know, of course.
It's beautiful.
Beautiful, but does she have a good heart? She has. I met her several times. She also came to our hospital. I don't think she will recognize me because she didn't have any constipation at that time. Next slide. This is what she looks like also. And the next slide shows you how she is now. This is a picture of a few weeks ago. So I share it with you. You know she's in good hands. Holland is nice to her as you were to me. So thank you very much. So next slide, please. So now I have to talk about hospitals. And this is a little history about our own hospital. This was more than 150 years ago. This was in the center city. We don't have nurses like that anymore. The costs changed. Next slide, please. And this is the hospital I work in. This is the AMC. The couches are already disappeared because the hospital only grows and grows. Next slide, please. And the top floor is the pediatric ward. So these are the wards in Amsterdam. And sometimes I'm ashamed when I tell the stories about our own hospital because, as you see, it's so luxury. And I can tell you that all the people in Holland are always complaining because the internet is not fast enough, the food is not warm, the doctors are 5 minutes late, and then they're in these circumstances because the children are sometimes with 2 in a room, but most of them have 1 room by themselves. The parents can stay inside, have their dinner, Everything is arranged. And still people in Holland are complaining. So that's nice. So if you come to Holland, Amsterdam, I love to show you around. And this is what it looks like. Next slide, please. This was the very nice part of the slide. You can sleep now because I will discuss constipation with you. And this is the definition you are aware of. These are the wrong criteria, the wrong four. And of course, you will, and I don't think it will change in row 5 because this is what it is. Why did we divide it? Because fecal incontinence is the most important symptom of constipation. And of course, you have to require continence. So that's why the age of 4 was introduced. So infrequent hard stools. If you want to do, you can do a physical examination, although we also wrote that if you have 2 symptoms of constipation, for instance, infrequent stools with fecal incontinence, then you know that the rectum will be full and a rectal examination is not necessary anymore. Next slide, please. Next slide. And this is the prevalence of constipation. Next slide. And as you can see, that almost 10% of the world has of the children have constipation, and this is everywhere. I have no clue why it is, because we did lots of research with the people from Sri Lanka, and they have a different culture, they have a different temperature, they have a different food habit, and still the prevalence in these countries is exactly the same. Some people think about the microbiome. I don't know if this is really true, but so it's very difficult to understand why so many children in the world have constipation with such a different background. But you can imagine, because we do think that the majority of children do have withholding behavior, and you don't need another background to withhold your stools. Next slide, please. So very difficult slide. I made it myself. But these are the factors involved in constipation. The left part, the top left of the panel is probably the most important factor of constipation, as I told you, which is behavior with respect to withholding behavior. So the child contracts instead of relaxes their sphincter complex. And this is all over the world, probably the major pathophysiological mechanism to understand constipation. But as I told you yesterday, abuse, you have to ask about abuse. You have to ask about abuse because it's important. It's a difficult question, but if you ask the question in a polite way, nobody will be angry. Moreover, I think that many people in the Netherlands, I don't know how it is in Argentina, they think, did something happen somewhere? And it might be physical abuse or sexual abuse, but it's never a surprise for them if you ask it in a polite way. So food, I come back to that later. We have no clue about genetics. There was no gene found yet, which was related to constipation. We did some research in microbiome, didn't find anything. And then, of course, more rare are the nerves, the muscles, and the interstitial cells of Garrahan. But all 3 of them, it's very difficult. I faced so many children with constipation. And sometimes we send our full thickness biopsies to other countries. They never find something. And still, these children defecate once a month or so. Okay, and then we will talk about the colon later on. Next slide, please. So I tell you just a story, the true story of a patient who came to the clinics. She was 14 years old and was referred because of fecal incontinence. And at that time, she was using intensive laxative treatment. Next slide, please. So what do I ask? Even if the child is 14 years of age, you never know if there's an underlying Hirschsprung's disease. So, and I'm always surprised that many mothers, hardly any fathers, know about the first stools of their child. So in this case, they didn't know, but in the majority of cases, they did know. And the child was toilet trained around the age of 3. Next slide. And then the parents told me that she has fecal incontinence since the age of 4 years. Next slide. And then there's a gap. And this is not very often in my practice, but there was a delay of 7 years going to a doctor. So probably the parents were ashamed, or they didn't recognize it, or they asked the neighbors, oh, I have a child who was also late in toilet training, but 11 years, it's ridiculous. So next slide. So then she was referred to the general pediatrician. And I don't know if you recognize all these kind of treatments, but I assume that you do exactly the same as here. So you give some toilet advice, which means 3 times to the bathroom after each meal for 5 minutes. Many of you give diet advices, more fibers, or fluid. You do?
Yes.
Yes, it's wrong. Okay. And then you give these kind of laxatives as well. Polyethylene glycol, lactulose, bisacodil. And biofeedback, do you use biofeedback? Yes. Okay. So that's what they did. Next slide, please. So let's talk about increased fluid intake. Okay, next slide. Because there are data on this, and I think as a general pediatrician or pediatric gastroenterologist, we have to know. So this was a nice study back in the 90s, and they divided. They included more than 100 children with constipation, and as you can see, they had a control group, an increased water intake group, and increased osmolarity of the fluids. They used a score I'm not aware of. But they said, well, if the constipation assessment scale is over 8, then you have constipation. And then the next slide, hopefully not to your surprise, but it has no single effect on stool frequency, on stool consistency, and on difficulty in getting out the feces. So if you have your medical history and the fluid intake is sufficient, and there's no temperature of 40 degrees outside that the child is sweating, of course, then you're safe. And then if you give more fluid, you don't poop, you go and urinate. Okay? So there's no sense to increase the fluid intake if the fluid intake is sufficient. Okay, next slide. Then what about fibers? Because this is also a very difficult topic. So wherever you live in the world, all pediatricians will tell you we increase the fiber intake. So this was a very nice study done by Peter Sullivan, a doctor in the UK, and he asked his patients, how much fibers do you ingest daily? And as you can see, the majority of children didn't ingest fiber as much as we suggest. It's the age plus 5 grams per day. Is this uncommon? No, it isn't. This is in 40 to 50% of all children worldwide. So there is not enough fiber intake. So then he had a psychologist and a dietitian who worked on diet intake. And after 3 months, next slide, yes, there was an increase in fiber intake. And after 6 months, it sustained. Next slide, please. And yes, he was able to change the fiber intake. And then they looked at constipation again. Next slide, please. And as you can, there's a slide missing. Please go back. So at the end of the day, defecation frequency stayed exactly the same. The laxative intake didn't change at all in all 3 groups. So fiber intake, so it might be the case that in countries where the fiber intake is low, there is more constipation. But if you have to treat these children with fibers, it's not helpful. And all other studies using fibers in a randomized controlled fashion don't show any benefit of fibers. It's not minus A, it's fact of life if you look at the... So please ask for fluid intake if it's sufficient, don't increase fluid. Please ask for fibers if it's sufficient, don't increase fiber. And never treat a child only with fibers if it's constipated because it's not helpful. Next slide, please. So, back again to the patient, can you give polyethylene glycol early in life? And this is a systematic review showing, next slide. Next slide, next slide. I'm sorry. Okay. And as you can see, almost 500 children were included. And the most important message of this slide is that you can give polyethylene glycol from day 1 in life very safely with hardly any side effects. Okay, so in this case of this girl, she should be treated when she was 4 with polyethylene glycol. Next slide, please. Is it better than lactulose? I don't know. You know, lactulose has a little bit more side effects of bloating and abdominal pain, but I don't know how much you use it, but it's a very good alternative for polyethylene glycol and very cheap. Next slide. But the guidelines now say, well, polyethylene glycol is our first choice. But again, if you look at defecation frequency and fecal incontinence frequency, exactly the same. But the side effects of lactulose are a little bit more. Next slide, please. Next slide. So then about bisacodyl, because in the Netherlands, and I don't know how it is in Argentina, doctors are a little bit afraid for bisacodyl. So it has been assumed that you get abnormalities in the colon, that you destroy your nerves and and nobody knows if this is really true. But there's this group from the United States who looked at it, and this is the normal pattern you see if you do a colonic manometry before and after giving bisacodyl, which gives rise to very good contractions, as you know. And this is also the side effect, you get abdominal pain. Next slide. But then they showed, and this is very good news for all of us, that it's very effective and well tolerated. Next slide. But this is also very important because the long-term uses in children is not associated with complications or development of tolerance, which is very, very important. So if you give it every other day, you're completely safe and you can give it for years, even in combination with polyethylene glycol. Very nice drug. And cheap. And this is also important because many people didn't believe it, but Sam Nurko and his group showed that the majority of patients are able to wean after a certain time. Okay. The next topic is also very important. So this girl at the age of 11 started with polyethylene glycol, lactulose, and had no single effect. But then if these children are reaching their adolescence, we as doctors have to acknowledge that compliance is a difficult thing in life, taking your medication. So we did a study looking at compliance in children with constipation. And then you have to think about, if you come to the AMC, our academic hospital, it's specialized in constipation. I'm really the true Willem Alexander, the king in the Netherlands. So you think you have authority. I'm very nice and very sweet and everything. So you hope that people listen to you. Because after me, there's nothing in the Netherlands because you can't go anywhere because you have seen. So we did this study. Next slide, please. And as you can see, most of the children, if they come to my office, they have constipation for 5 or 6 years already. Next slide. And then the patient takes the medication under supervision, mostly of the parents. And then the next slide is very disappointing because 40% of the patients did what I told them. That's sad news. So I don't know how it is in your hospital, but really think about compliance because it's misery. And now we do all these studies with children with functional abdominal pain. And if I ask the question, did you take your medication? They all say yes. But if you ask the question, do you ever forget your medication? Then they say, well, sometimes. And then you have to grab them in the neck. Because then you ask, okay, no worries, but how many times a week? Well, sometimes 4 times. Oh, 4 times a week. Oh, okay. And in that, oh, I forget it every day. And then you know exactly why your medication or treatment is not working. And this is disappointingly, the more experience I have, so common. So even in studies, it's we look at everything and still these people don't do what you're saying. So this is a problem. Okay, next slide, please. So you send the patients to the biofeedback. And this is a study which was published in Gastroenterology. I don't know why, but it was published in Gastroenterology because only 50 children were included and they received either the pelvic physiotherapy and they compared it with standard medical care. Next slide, please. And it's the standard medical care in constipation only consists of education, toilet training, and laxatives, as I showed you, and the pelvic floor physiotherapy as specific physiotherapeutic interventions with balloons and sensation, etc. Next slide, please. And this was striking. I put the red and the yellow color wrongly. So there was more than 90% success of children receiving pelvic physiotherapy. This is exceptionally high because all the studies I have been doing never showed an effect of 90% in children with constipation. It's always like 60%. So this is strange, but okay, this was the result of this study. So there's no adverse effect of physiotherapy or biofeedback, so you can send your patients to such a healthcare professional. Next slide, please. But then the study was repeated, not in a general hospital, but in the general practitioner's hospital, in general practitioner clinic. And I don't know if you have the same. So we in Holland, we have general practitioners, the general pediatrician, and the pediatric gastroenterologist. So the majority of children will only see not by a pediatrician, by a general practitioner. And they didn't see any difference between the two therapies. So this is strange. Very inconsistent data, but this study has more than 200 children in their study. So it's up to you to send your child to these kind of healthcare professionals. Next slide, please. And this was my own study when I started to study constipation. So we included 200 patients, and we did biofeedback, which is very similar to pelvic floor physiotherapy. And as you can see, automatically there was no single difference between the two therapies, between those children who received biofeedback training or in addition to conventional therapy compared to conventional therapy alone. So in my hands, I did it for 5 years. It was a very negative study. Next. So we're going back to the patient. So when I did the medical history, again, if you ask something about defecation in your patients, then many patients will tell you, well, we defecate every day. But defecation in a diaper or in the underwear is completely different than defecation on the toilet. So if she had like 10 times per day defecation, which is no defecation, of course, it's fecal incontinence all day long. So she never defecates at the toilet. Next slide, for years. And then she has sometimes 5 or 10 times per day loss of stools in the underwear. And a very important question in these kind of children, you have to ask what the timing is of the loss of fecal material. If the patient tells you it's during the night, it's the most severe sign of constipation. So you do know that the rectum is in an abnormal way distended. So fecal incontinence during the night is directly related with a very distended and full rectum. Next slide, please. In this case, she told me she has no withholding behavior anymore. It could be that she had withholding behavior when she was very young, but at this point, when she was 14, when I saw her, she had no withholding behavior. She discussed abdominal pain, but as you know, only 50% of the children with constipation have abdominal pain, and no other symptoms. She had a good appetite. Look here, fiber and fluid intake was sufficient. And this was her social history. She went to high school. There was no bullying, no sexual physical abuse, and she plays soccer. Not for River Plate, but she plays soccer. And she has a sister with constipation. And this is I don't know if it's a coincidence because as I told you, there's no genetic association with constipation, but we do know that first-degree relatives have constipation in children with constipation. Physical examination, there was no palpable mass, no dimple, anal wink. Anal wink might be related to neurological abnormalities. Although she was 14 years of age, when I saw her anus, it was surrounded by feces. Next slide, please. She had a normal sphincter tone, but the ampulla was totally filled with fecal material. Okay. So now I have a question. Oh, go back, please. Because I wanted to ask you a question. What do you do now in this patient? X-ray? Okay. But the thing is, never make an X-ray without markers because it doesn't say anything. It's so difficult to rate. So we did, I think, 10 studies to show whatever system you use to look at an abdominal X-ray, it doesn't work because what we did, we had like 500 photos of children with constipation. We asked several people to rate the abdominal X-ray. And then 1 month later, we asked, they didn't know, but we sent the same pictures. Then they had to rate them again. There was a big difference between their first rating and their second rating among themselves, but also there was a big difference, every system they used between the raters. So if you were very experienced or not experienced, it didn't make any sense. It didn't make any difference. So please use Marcus because then you have more insight. So this was her picture. I used the Marcus study. Next slide, please. And this is what you see. Okay, on the left panel, there's a lot of air. On the right side of the colon, there is feces, and in the rectum, there is also a lot of feces. And the markers in the majority are in the rectum, which is associated with outlet obstruction. Okay, next slide, please. When he started to measure the rectum, it was really, really distended. And I already told you she lost feces during the night, so this was not a surprise to me. So next slide. But then I do a barium enema, and I do this since 5 years. Because in the past I thought it was too much radiation, it's not helpful. But in my opinion, it's very helpful because this is the same child. And if you look at the picture, you wouldn't, you couldn't imagine that the colon was so long and so wide. So this is totally new for me. So in the very, very difficult constipated children are nowadays, I make all these barium enemas, and well, we have seen so many children with abnormally elongated and widened colon. So this is strange, okay? Because I have to admit, I have no clue how a normal colon in 1,000 Argentinian children who have no constipation, what they look like. So we need those studies as well, okay? But this is, to my opinion, very abnormal. Next slide, please. So if you look at the pyramid of constipation, severe constipation, so they did education, toilet training, etc. Then they used the regular laxatives, they gave a stimulant, and now transanal irrigation. So my question to you is, do you use transanal irrigation in your country? And who is doing this? Can I see hands? Not everybody. Okay. And is there, do you understand English very well? Upstairs?
No, they're not doctors.
You're not a doctor. Oh, you're lucky. Okay. Okay. So, because if you talk to American doctors or English doctors or Canadian doctors, they hate to stick something in the bottom. Is it true? Not true? Well, in many parts, they don't like the anal irrigation. And this is probably a cultural thing. So next slide, we love it. So next slide, please. So these are the things you might use, because these are the different systems. At the bottom left, there's some Equinox. They're small, but they are more painful than the bigger enemas. Did you know? So we always, as pediatricians, think if it's small, it's not painful, but it's the other way around. So if you use the fleet enema, it's less painful than the Equinox. It's because of the contents of the fluid material. And what we do with the small children, we use half of the fleet enemas. And on the right, there are the new systems to do the rectal, the transanal irrigation. Next slide. Indications, well, there are several. Next slide. Next slide. Next slide. These are the indications for transanal irrigation. So for the spina bifida, it's very, very helpful. Of course, after surgery, well, tumor surgery is very, very rare. And of course, in the medical therapy, resistant functional constipation inside. And also in those cases where I told you yesterday about was the functional morbid and the fecal incontinence, where it might be helpful as well. Next slide. Next slide. Next slide. Next slide. Go on to the end of the slide. Yes, thanks. So there is good research on this. It's not new. So more than 1,000 patients are described, of whom the majority has neuropathic dysfunction. The satisfaction rates among children and parents is very, very high. quality of life improvement is very high, and this is only because they have no fecal incontinence anymore, which is the most frustrating sign in these children. Of course, there are side effects. If a child refuses in the first week the transanal irrigation, please stop, because then you lose it, and then do it few months later or a few years later. But otherwise, it's like a rape. I always tell the patient and the parents, because if they don't want it, it's no sense to go on. Okay, and then please ask about compliance, because again, that's very important. Next slide, please. So what do we use? This is our own data. Please read it yourself. You can put in the fluid whatever you like. And most of the children do it on water, a little warm, but you can add bisoconazole if you like. Some people add polyethylene glycol. Well, you can read it yourself. But some people like to do better on saline. I have no clue why, but this is real life. Next slide, please. Do children need additional medication? I leave it to the parents, because you can imagine if you empty the last part of the colon, it's very effective, and it might be the case if you make the features too soft that they lose stools because of the consistency of the stools. But other parents like it to add oral laxatives because it makes children more easy to defecate, even when they have the colonic irrigation. So there is no strict rule. You just discuss it with the parents what they experience as best way to do it. Next. And these are the very good data showing that the majority of children, like 60% in this case, hardly have any fecal incontinence after a week. It's fantastic. Okay, next slide. Satisfaction, well, the same as the literature says. Next slide. Next slide. This is also very important, because always the question to me is, how long do we need it? I'm not a magician, so I have no clue how long. But if you need to use it forever, it's fine with me if you have a better life, because it's about the child, how if he or she is able to continue to do it daily or every other day or twice a week. But if it means that the child is completely continent, goes to school and has no other problems, I have no problem to do this every day. And why do I say this? Because your patients with spina bifida, they need it for life. They don't make a problem. And of course, they feel less sensation than the children with constipation. But I never had children who became 18 and were still using transanal irrigation. But I don't know for how long, but I don't care the duration. Next slide, please. There are complications, of course. Some children report pain during the insertion of the catheter. Of course, it will, after a while, it gives emotional distress to do this daily or whatever. Catheter expulsions, the burst of the balloon is rarely. There's leakage, of course, and some children report abdominal pain during the anal irrigation. And this is the bowel perforation. We never had it, but this is complete. Okay, next slide. I'll skip the slide. Next slide, please. Okay, so the child, in this case, a 14-year-old girl, didn't like the irrigation not that much, so she was asking for new medications. Okay, let's see what there is. Next slide. So this was the study we did a few years ago about precalopride. It's a colokinetic. It might be very good for children with gastroparesis as well, so you can try it. It's expensive, 100 euros per month. In Holland, you have no insurance for this, so the parents have to pay it themselves. But the results, in contrast to the adults with constipation, was very disappointing, because as you can see, there was only 18% success rate in both groups, and no difference for compared to placebo. And more importantly, although I have to say that some patients with constipation do really well on this drug, but if you look at the data, they're not good. Next slide. Then lubiprostone, which is selectively activates the chloride channels. which enhances intestinal fluid secretion and increased motility. Very good data in adults again with constipation, irritable bowel syndrome with constipation. No data in children, but we did a large study, next slide, and again, negative results. So this is disappointing because the adults always report very good results, but I do honestly think that I don't know how they have all these positive results. But if you look at the data of lubiprostone in adults, it's almost similar, 20% in their population, but the placebo rate is only 9%. So this makes a difference. And we have to admit that in children, withholding behavior is probably the major sign, and you can't change the withholding behavior only with medication in a short period. So again, negative result, but I honestly do think that lubiprostone will work in some of your children. Next slide, but again, expensive. Botox. Who's using Botox? For yourself? So this is what I learned from the Americans, because I never used Botox for myself. Next slide, please. This is strange because these papers by these Americans, they have several papers on Botox. You know, and did it in manometry studies. It doesn't matter at all. If you have a high sphincter pressure, low sphincter pressure, if you withhold, not withhold, in their hands, everything is successful. So you inject the Botox in 4 quadrants in the anus. I do it in many very young children. And then if you look at these data, it's fantastic. Next slide. But as you know, Botox doesn't last very long in many people. So 20% of the initial improvement lasting at least 2 weeks. Next slide. 33 had a response lasting between 6 and 12 months, which is really long. Next slide. And 70% even had a response lasting longer than 1 year. In the majority of children I treat, there's a response of 3 months, 2 to 3 months. And if it doesn't work for longer than 1 month, I stop because it's expensive. You need general anesthesia, and it's very painful. Even the children who are under general anesthesia, you notice that it's painful if you inject the fluid. Okay, next slide. Next slide. And then fecal soiling, but also urinary incontinence might be a complication in the first days after you have given the Botox. Only retrospective studies, general anesthesia, placebo is lacking, and very high cost. So, but in some babies, it really works really good. It's better than surgery. Next slide, please. Going back to the 14-year-old colonic irrigation, still fecal incontinence. Then I do most of the time, I do a marker study to see if it's successful, if she's not lying to me, if she's doing it, if the compliance is good. But it was too much for her. Then I discussed the next step. Do you want a succostomy, or do you want sacral neuromodulation? And the only thing she said to me, don't discuss anything with me, take my colon out. Okay, I like to see hands. Who wants to have surgery now? Do you do surgery in this patient? What would be your decision? What would be your way to go? So nothing, you gave oral laxative, rectal laxatives, she was compliant, still has fecal incontinence daily. So we have to do something.
Maybe so.
Yes, please.
I will do the surgery because I'm a surgeon, so it's not a hard question for me.
Okay.
I will do sacral irrigation.
And do you have sacral
That's one.
Okay. And do you have it in Argentina as well?
Yes, we are starting with it.
Okay. And Emmanuel, because that's minor surgery, although it's surgery, would you prefer surgery? Because then you give the fluids not rectally, but you give it via the cecum. Can I see hands for this? Only the surgeon. Okay.
If sacral.
Okay. If you decide to do a Malone, you have to know if he's able to expel the fluid you introduce in the rectum. Because if it doesn't work there, never do them alone because she won't expel it. And that's a big mistake surgeons make. Okay, next slide. So let's talk about sacral nerve stimulation. Next slide, please. How does it work? You introduce a lead with the needle and you go to the sacral nerves. Next slide, please. And then there's a test period of 3 weeks. And during these 3 weeks, you should notice an improvement in defecation, an improvement in incontinence. And if it really works well, then abdominal pain will disappear. Next slide, please. And this is what it looks like on an X-ray. Okay? We don't know exactly how it works. But we showed in my intractable patients a very good success rate of 70%, I think 10 years ago. Okay, next slide. There were many people who said sacral nerve stimulation is not working, although we showed in our papers together with Carlo Di Lorenzo in later studies that it works quite well. So that's why we started an open label, multi-center open label trial together with the adults, because there are not enough patients to include in these kind of studies. Next slide. The inclusion criteria, 14 to 80 years with constipation. They should have slow transit constipation. How did we diagnose this with a marker test? And they shouldn't have outlet obstruction, as I showed you, if the markers were positioned in the rectum, because it means that if you, you hope that you will better contract the colon with your sacral nerve stimulation, that if you do this to a closed door, it won't help. Okay, so we showed together with defecography that all these children and adults were able to expel the feces. So next slide. Next slide. So these were the patients included. So we were able to include almost 70 patients. Most of them were adults. They had constipation for years and years and years and years. The colonic transit time was really extended. Next slide, please. The results were sensational because I've never had this before. Because if you look at it, so the people who received the conventional therapy were able to do the transanal irrigation every day. Was only one. And the people who were in the group without sacral nerve stimulation, and 60% had good scores at the end of the study. So next slide, and this was true for the defecation frequency as well. Next slide. And of course, there are some side effects of this, but nowadays, because there are inconsistent data, for the last 2 years, we are not able to publish the paper. So we send it to many, many journals. And every time we have believers and non-believers, and these are the data. We didn't do nothing with the data. These are the data, but it's not accepted yet. And more disappointingly, the company who sponsors the trial and who makes the devices stopped making the devices, particularly for constipation. So it's there for fecal incontinence, for urinary incontinence, but there's nothing for constipation. So very disappointing, although we showed that it's really effective and would be helpful because it's nothing to put the leads in. Next slide, please. Okay, we tried sacral nerve stimulation, it didn't work. Surgeon? Okay, but now my question to you is, how many of you sent your patient to a surgeon for constipation? Very few. In the United States?
Yeah, we do. Not often, but we do.
And what is not often? In the last 10 years?
How many I personally sent?
Yes.
3 or 4 in the last 10 or 15 years.
Okay. Did you ever operate a child with constipation?
Yeah.
Yeah, but not Hirschsprung's disease, functional constipation.
It depends on what means a surgery. Because
What means it to you?
it's a procedure that we do.
I know.
Yeah.
So what do you do?
No, it depends. It depends on the problem because
Indeed. Okay, but no. I make life difficult for you. You're not a politician. So in this case, What would you prefer?
In this case,
Yes.
that this girl had the colon enema that,
Yes.
with the long colon.
Yes.
Well, I would propose to take some of the colon out.
What
Like
some?
of the
What some?
the sigmoid part that goes up and goes down, that is not fixed to the wall, that it's moving around like anarchy.
Okay.
I would think that most probably part of the problem of the constipation of this girl is that the sigmoid part that is too long for her. It's not anatomical and it's weird and it's not frequent. I think it's part of the.
Okay. And what's the origin of this?
The origin, it's like the egg and the chicken. I know, for me, at least, it's the constipation causing this, or this causes the constipation. I don't know. It may be anatomical, and it's a variation.
This is exactly our problem, because these parents ask me or the others, what's the reason my daughter has this? You know, in this case, she waited too long to go to a doctor. There was a delay of 7 years. So if you don't go to the toilet only once every week or every 2 weeks, the rectum will distend, the compliance will disappear. And then, in my opinion, the colon can get elongated over the years. But again, I'm not a magician, so I never took an enema when she was a baby. It might be the case that she always had an elongated colon, but we don't know. So I absolutely agree with you. Okay, let's see what we did. Yes.
We want to do a colonic manometry.
Very good question. And so the question is, do we now need a colonic manometry? We did in the past, in all these children. I'm by myself. There's only one American, although he's not truly American. Some of the American hospitals do think that a colonic manometry is necessary in these cases. I don't think so. Because in some of these children, you will find abnormal colonic motility patterns. But we did it, and in many of these children, we didn't see anything, and we still had to decide what to do. But if you look at the literature, some people say that if you have no motility in the majority, in the major part of the colon, take out the colon. So based on that, but we do it basically on the markers. What is difficult for us is one, it's a very invasive procedure. It's very difficult to because it's not so easy to put the catheter in the cecum, although you always see these very nice pictures, but in 1/3 or 2/3 of the patient, you never reach the cecum in these very elongated colons. It's very expensive. And I think that the system in the Netherlands, and I don't know how it is in Argentina, but it's not based on money. So if you really need it, then we do it. But otherwise, we don't do it. So like endoscopies, it's a small part of the children we will do it. Okay, next slide. So there's the surgical options. Next slide. So this is what we do. And in the last 15 years or so, we operated 150 children with constipation. And it's a very, very difficult decision. I find it, the older I get, I find it more and more difficult to decide. So we have a large group of people who decide with me: a dietitian, a physiotherapist, a general pediatrician, a social pediatrician, a pediatric surgeon, a pediatric psychiatrist, a pediatric psychologist. And we come together every 2 weeks and talk about these terrible cases. And they are so dangerous, these cases as well, because as I told you, the compliance is difficult. The system, the parents are fed up with the constipation, with the incontinence, with the smell in their houses, and they want us to do something right now. And the older I get, I'm more find it difficult to take the decision. But this is what you can do. You now use the change, which is in blue. It's like you use it for the succostomy, and then you can partly resect the colon, take out the whole colon, and you see the stomas. Next slide, please. We have also had dilemmas, and we also already discussed it, because can we predict which child will do well on these terrible interventions? Which diagnostic test is best? If you do it, and when to do them alone, a colostoma, an ileostoma. Once you remove the stoma, if you do it in 16 years old girls, they are very happy that they are not incontinent anymore, but after 3 months. They want to get rid of the stoma because they don't like it. They have a new boyfriend. And then do you resect the colon, the sigmoid? Very difficult decisions. So what we do now, we take the children in the hospital for at least a week, just to look at them, observe them, what they do, if they irrigate, what helps. We do a marker test during the week. And then decide what to do together with the whole team. Next slide. Many of these children, it's also associated with psychiatry. So you definitely need the psychologist or the psychiatrist. Next slide. And this is the most terrible thing. And we have to think about it every single day in an academic hospital, because I faced it 5 to 10 times per year, fictitious disorder. Even the last child we operated on, what we got to know after 2 years of treatment and taking out her colon, that she was stealing the medication of her parents, the morphine drugs of her parents. So during the market test, which showed no any movement, she probably took the drugs and never told us. So this is a big problem. So you have to keep it in mind. Next slide, please. So if you see this, I agree with the surgeon, it's easy, because then you take out the standard part, because this is only sigmoid. And these are the most favorable patients to operate. If they only have a distended sigmoid, which can sometimes be 50, 60 centimeters or even a meter we have, then take it out and you're fine. Next slide. These are our data published in 2020. In this case, 40 children with functional constipation. The next slide. In majority, we started with an ileostomy. We don't do it anymore. So it's behind us now because we have so many problems with this, the stomies. Next slide, please. The children stayed in the hospital for at least 9 days. And compared to the, for instance, children who we operated on IBD, they are much more pain. They are much more in pain than the IBD patients. We have no idea why, but their sensation is completely different than in IBD. So we have to be aware of that. Next slide, please. Complication rate. Although surgeons never have complications, never. But in our hands, very experienced surgeons, they still have 95% complication rate, which means they have pain around the stomy, granulation, all these very minor things. But sometimes there's major surgery necessary after a while. Next slide. And some of them have pre-operations. Next slide. This is also strange to me. So over all these children where we did these terrible interventions, the parental satisfaction rate was really, really, really high. So after 1 year, we asked all the parents, would you do it again? After being in hospital for months or for weeks or whatever. So this was strange to us. So they would advise other parents with these kind of patients to go for surgery at the end of the day. Remember, all these children had constipation for 10 years. They had not 1 day constipation. Next slide. So what happened to the patient? This is a very successful story, of course. I can tell you the most terrible stories as well. She did really, really well. So she had a laparoscopic anticystic subtotal colectomy with an ileorectal anastomosis, which is nowadays our preferred way to go. And everything went well. And when we follow her, she's still doing really fine. But again, this is one of our most favorite patients. It's always nice to have a good story, but I can also tell you stories about children who fail. But of course, we have like 60-70% of the children is really happy with what we have done. Okay, next slide. So don't forget, when I started to study medicine, my professor always told me constipation will disappear during after puberty. But these are the true data, because I was not believing in, never believe a professor, because I kept following these children. And as you can see, after 15 years of follow-up, at least 20% of the patients still have the same problems as 15 years ago. 20%, 20. Okay, next slide. So, at the end of the day in Buenos Aires, before the soccer match starts, I think constipation is a very serious problem, and you should take it seriously. In some of these children, the symptoms are long-lasting, but we do know we have no good data from general hospitals. So all the data here presented in the world are from academics hospitals, but it might be the case that 90% of all children with constipation, if they are treated in an early way, that most of them will never have constipation again afterwards. And of course, randomized controlled trials are necessary because I showed you that the drugs which were successful in adults are not always successful in children. And in the next 2 or 3 months, there will be a new paper on linaclotide, which also was successful in adults, and is a positive for the first time, a positive study in children. So it will be presented at DDW in a few weeks' time. Do you agree? Well, thank you very much for your attention.
Muchísimas gracias, doctor Benninga, por este fascinante recorrido de la fisiología, fisiopatología y el tratamiento de la constipación, ejemplificado con un paciente que puede ser parecido al que cualquiera de nosotros tenemos. Tenemos uno muy breve para contarle, 5 minutos, un niño que creo que va siguiendo este camino. Queremos saber cuál es su opinión y bueno, y la de todos los concurrentes. Vamos a presentar el doctor Adrián Zapata. Si quiere tomar asiento.
No, that's fine, it's fine, it's fine.
Buenos días. Bueno, es un caso de una constipación crónica refractaria que vamos a presentar a continuación. Siguiente. Bueno, es un paciente masculino de 12 años de edad con unos antecedentes perinatológicos que no tienen mayor relevancia, con un mecón en las 24-48 horas posterior al nacimiento y un FEI normal. Como antecedentes personales, es un paciente que presentaba constipación desde los primeros días de vida y que requirió múltiples tratamientos, especialmente con enemas oleosalino. Por estos múltiples tratamientos realizados, que no tuvieron una buena respuesta del paciente. Nosotros lo conocemos en nuestro hospital aproximadamente a los 10 años, que viene por una segunda opinión, por la persistencia de la constipación y la baja incontinencia que tenía a nivel fecal. Siguiente. Dentro de los estudios que hicimos...
I think the audience has questions now. Please go back. So what do you want to know? Because I want to know many things.
Okay. ¿Alguna pregunta?
Bueno.
Bueno, los tratamientos que le habían realizado previamente habían hecho laxantes orales, los cuales estuvo el lactulón y el polietilenglicol, y concomitantemente, como tenía varios efectos de constipación e impactación, hicieron tratamientos con enemas oleosalinos. Y en los últimos tiempos, que lo vamos a ver posteriormente, hacían enemol de forma constante para mantenerse limpio.
What happened between the first year and the day you saw him at 10 years? So what kind of therapies did he receive?
Los laxantes orales y le hacían los enemas oleosalinos.
What was the dosage?
Las dosis, o sea, las iban modificando según la edad del niño, porque comenzó desde los primeros años de vida, pero nosotros recién lo conocemos a los 10 años.
Okay, and was he between the first year and the 10 years, was he ever good? Was he, for instance, 1 year or 2 years, he was never good. So he was oral and rectal laxative without any response. Okay, and did you check the compliance?
Según, era muy mala la trayectoria, toda la información que nos dio la madre de los años previos, de pronto no estaba todo muy bien cronológicamente dado por la mamá, pero en breves rasgos el cumplimiento era parcial y tampoco tuvo una buena respuesta al tratamiento, a pesar de que seguía las indicaciones.
Okay, and so you did the rectal laxatives and the enemas. For how many did he receive? Did he receive it daily, or was it once every year, or how did it go?
Los laxantes lo recibía de forma diaria. Detalles que a veces en la modificación y los requerimientos de...
But I mean the rectal laxatives, the enemas.
El enemol. El enemol refería a la mamá que lo usaba por lo menos cada 2 o 3 días. Los rectales.
And was it successful?
Con eso no se mantenía limpio del todo, pero la mamá lo hacía de forma constante para intentar lograr el éxito.
Okay. And so when you saw him, what was the fecal incontinence like? How many times per week or per day, or was it even during the day, during the night?
Refería que tenía en el día constantemente presentaba pérdidas a nivel de incontinencia fecal, y refería también que presentaba la ausencia de posiciones. Casi siempre era máximo 2 veces a la semana que tenía deposiciones.
¿Esas deposiciones eran en el baño?
Según lo que refería el paciente, sí.
¿Tenía sensación? ¿Iba al baño?
No, tenía más hábito de contener o de retentivo.
And when you saw, did you do any physical examination?
En el momento se valoró, cuando se hizo la valoración, tenía un abdomen distendido con presencia de asas intestinales también distendidas, y tenía abundante materia fecal, especialmente a nivel de colon sigmoideo y a nivel de recto. Igual lo van a ver en la primera radiografía, tenía abundante materia fecal.
No, but did you do regular examination?
A veces en la primera valoración médica de nuestra parte de pediatría intentamos no hacer el tacto en la primera consulta para no ser como tan invasivo.
Bueno.
Lo que sí hacemos es que le hacemos la palpación y hacemos una inspección por lo menos. En ese momento se veía sucio.
Okay. Okay. No questions anymore.
¿Alguna otra pregunta? ¿Alguna otra pregunta del público?
¿Y las internaciones por su oclusión o por dilatación?
El detalle es que la mamá no tenía toda la parte de las diferentes internaciones, no era el relato cronológico que nos daba ella como tal verbalmente que físico.
Ok.
Siguiente. Entonces, dentro de los estudios que realizamos en nuestro hospital, le hacemos el laboratorio completo, en el cual hacemos el perfil tiroideo, el hemograma, el coagulograma, el hepatograma y todo lo que es la parte del medio interno. Y concomitantes se le hicieron los anticuerpos para celiaquía, los cuales fueron negativos. Dentro de las radiografías de abdomen, como lo podemos visualizar, se ven las asas, especialmente de colon transverso.
I have a question to the audience again. Who's doing all these labs in a child with constipation?
Usually no, but it's 10 years old.
Okay. Okay, so do you know the results of labs in constipation? You have the chance you have a positive results? 0.01%. 0.01%. Okay, so if you have only the sign of constipation without any other sign of signs for hypothyroidism or celiac disease or whatever, the chance is even lower. Bad news for all of us, but you can keep it in your pocket. Okay.
Yeah, but it's 10 years old. 10 years of constipation.
I know, but negative result. Okay, please go on. So can somebody can you describe what you see on the X-ray?
Bueno, en la radiografía, por ejemplo, va a describir la del medio y la última. En la del medio vemos un colon especialmente que se ve dilatado a nivel de asas, el colon descendente y el colon transverso, abundante aire, y en la que está en la última fotografía vemos que contiene abundante materia fecal, especialmente a nivel rectal y en colon sigmoideo, que se ve la imagen en miga de pan como tal en dicha zona. Y también concomitante el ángulo colon, sí, se ve dilatado el recto como tal. Tiene abundante capacidad de acumular materia fecal allí.
Perdón, les voy a hacer un pedido. Nos dice la traductora que continuemos hablando con el micrófono porque si no ella no puede traducir. ¿Sí? Así que les voy a pasar los comentarios del público que por favor los hagamos con micrófono. ¿Sí?
Voy pasando el micrófono. Bueno, como lo dice el doctor, vemos en la última placa que tiene un recto con un diámetro aumentado, que lo que nos quiere decir es que tiene un periodo de continencia muy elevado, o sea, mucho tiempo de retención, perdón. Siguiente. Bueno, para continuar con los estudios se le hizo un colon por enema, el cual, como lo podemos ver, tiene su dilatación a nivel rectal, pero no se ve ningún cambio de calibre a nivel de, por lo menos el colon sigmoide, lo que alcanzamos a ver en esta imagen. Pues vimos toda la imagen, no tenía ningún tipo de signos de estenosis o de disminución del calibre. Siguiente. Bueno, posterior colon por enema se hizo aproximadamente 5 días después, se le hizo una radiografía con tránsito con marcadores radiopacos, que se hizo el 5 de julio del año previo. En esta hicimos la radiografía posterior a la ingesta de los radiomarcadores y en el 5.º día se veía todavía presencia del contraste del colon por enema que se había hecho previamente y unas cuantas arandelas a nivel de colon descendente, ¿sí? Y lo más seguro es que la mayoría de arandelas o marcadores se encontraban a nivel del recto. Por dicha razón, como no había tenido la eliminación como tal de todo el material, unos meses después nuevamente se hace una nueva radiografía y se ve que todavía tenía todo este contenido a nivel de la parte distal del intestino y por dicho procedimiento se le hizo un enema oleosalino en el cual se vio que salió abundante materia fecal y el resto de marcadores radiopacos. ¿Alguna pregunta? Bueno, siguiente.
Quería preguntar algo. Ustedes ahí cuando previo a hacer los marcadores constataron, todo eso lo trajo previamente.
Exactamente.
Porque le hicieron los marcadores con el contraste y perdieron.
Eso fue fuera de la institución. Como tal, eso fueron estudios que ya lo había hecho previamente antes de llegar a nuestro hospital. Entonces, no, igual yo intento responder igual, para eso están las lecturas que tienen más conocimiento. Para continuar con los estudios, en el algoritmo hacemos una manometría anorrectal en la cual observamos que tuvo una presión de reposo de...
I have a very mean question to you, very mean.
Claro, con gusto.
Are you asking with a mean question? ¿Sí?
No hay problema.
Okay. So, why did you do a manometry?
Bueno, la finalidad es porque con la radiografía y con los marcadores pudimos ver que lo más seguro es que había una obstrucción del tracto de salida. Y para dicha razón necesitamos hacer una valoración.
Why do you care?
La finalidad es definir por qué el niño contiene tanto y por qué tiene la retención tan prolongada a nivel de su parte distal del
You have to make a manometry of his brain.
Yes.
No, because you know what's your if you go for a manometry, what's your question? So you want to address that there's withholding behavior. Is that the question? I asked it to you.
High pressures is the alta presión en el anal, probablemente sea disinérgico, disminución de la sensorialidad, mecanismos aferentes, parasimpáticos, simpáticos, es para medir toda la situación.
But did you already rule out Hirschsprung's disease with the biopsy?
No,
before you do a manometry, I would love to have the rectal suction biopsy. Because if you use the go on.
Antes de la manometría le haría la biopsia en este caso.
Yeah, for sure. Because you know, it might be the case. So you have a distended rectum. You show it beautifully on the picture. So the next step would be, if possible, but the manometry is a little bit more difficult in this case because the rectum is probably so much distended that you need like 500 or 1,000 mils in the balloon, and then it's uncertain if you see the rectal angle reflect, because that would be my goal. If you prefer a manometry, I am only interested in the reflex, because if you see the reflection, you do know that there's no Hirschsprung's disease. And for the rest, it's nice to know as a scientist, but I like to treat the child, and this is with irrigation or Botox, whatever, and I don't care anymore about all these kind of things. It's not wrong or right, but this is how we do it.
Nosotros tenemos disponibilidad para hacer la biopsia rectal y de hecho en pacientes en que tenemos fuerte sospecha de enfermedad de Hirschsprung la hacemos antes de la manometría. En este paciente que por historia y por enema no nos impresionaba que pudiera ser un Hirschsprung, preferimos hacer la manometría primero porque también en estos pacientes con megarecto nos resulta difícil a veces hacer la biopsia rectal y tenemos la pinza de Noble, tenemos la RBI2, la descartable, pero aún con esta que toma muestras más grandes, muchas veces tenemos muestras insuficientes. Entonces, si con la manometría, que nos resulta poco invasivo, tenemos una imagen clara de reflejo, no necesitamos hacer la biopsia. Por eso elegimos en este caso iniciar por la manometría.
Y para el tratamiento creo que también ayudaría.
Para el tratamiento, si descartamos Hirschsprung y encontramos otros hallazgos como el filtro medicinal.
La historia no daba para Hirschsprung, pero está bien, ahora con el reflejo presente ya descartamos Hirschsprung, con lo cual coincido con ellos.
But I fully agree, but it's sometimes nice to discuss why you do an investigation, if it helps you. And I tend, because in these very difficult cases, at the end of the day, you need to say yes or no Hirschsprung. Even if the history is like that, you never know. You never can ask the surgeon to perform any surgical intervention before you are really certain that there's yes or no Hirschsprung disease. So at the end of the day, you need to biopsy, whatever you see, because if you fail to see the rectal anal inhibitory reflex, you don't know if the reflex is not there, but it's caused by the distended rectum, and then you need the surgeon as well.
Siempre que planteamos un procedimiento quirúrgico, hacemos la biopsia de recto, aunque pensemos que no se trata de un Hirschsprung. De hecho, en todos los pacientes con pseudoobstrucción que van a ser sometidos a cirugía porque necesitan alguna ostomía descompresiva, la hacemos y estamos seguros de que no es un Hirschsprung. En este caso no habíamos llegado a la instancia quirúrgica, entonces preferimos ser más conservadores.
Yes, go, please.
Bueno, continúo entonces con la manometría. Adrián.
Perdón, no, quería hacer este comentario que a veces si uno se mete a hacer una biopsia sin tener todo lo previo totalmente seguro, porque en el colon por enema no era muy concluyente para pensar en un Hirschsprung, y la biopsia nos da que no se encuentran células, después también dudamos de la biopsia, porque todo lo anterior no estábamos seguros. Entonces entramos en una cosa que al final no le creemos a la biopsia, no tenemos un colon por enema compatible, y al final ¿para qué la hicimos? Entonces, pienso que la manometría es un punto intermedio que nos ayuda a tomar un camino antes de biopsiar.
Nuestro problema no es que no le creamos a la biopsia.
It was just for the discussion. I'm not angry, not disappointed. I still love you very much, all.
Nuestro problema no es no creerle a la anatomía patológica, porque aparte podemos hacer calretinina, y si tenemos una calretinina positiva se aleja todavía más la posibilidad de Hirschsprung. El tema es que en estos pacientes nos resulta difícil obtener material adecuado y tenemos que biopsiar y volver a biopsiar, y después a veces lo hacemos bajo anestesia para no molestar tanto al paciente y tomar muchas muestras, pero también es desalentador cuando uno no tiene una sospecha muy
If
fuerte.
it's really difficult, you can do the full thickness biopsy. You will always have the best result.
Pero ellos insisten con la biopsia rectal, no colaboran.
I know. Okay, go on, please.
Bueno, entonces continuando con la manometría, tenía una presión de reposo media de 56 milímetros de mercurio, una máxima de 75, una presión media de contracción voluntaria de 103 milímetros de mercurio. En el pujo relajaba, con la tos descendía, como lo vemos en la imagen del lado derecho, tenía un reflejo anal inhibitorio presente a los 60 centímetros y una sensorialidad con sensación a los 20 centímetros, una sensación defecatoria a los 40 y una urgencia defecatoria a los 240 centímetros. Como conclusión, entonces tenía una manometría sin trastorno del reflejo anal inhibitorio, sin desorden del tono ni la contractibilidad esfinteriana y relajaba ante el pujo. ¿Alguna pregunta? Siguiente. Entonces, vemos que el paciente tenía una evolución en cuanto a la parte de los tratamientos, con ingesta de xenócidos y mucílagos que aumentaron progresivamente la dosis sin respuesta. Se le hizo también la fisioterapia del piso pelviano, con lo cual tuvo una regular respuesta, logró algunas deposiciones espontáneas y suspendió la terapia y bueno, recayeron los síntomas. Y posteriormente se mantenía solo limpio con enemas de fosfato. ¿Alguna pregunta? Siguiente. Entonces, vamos a resumir el paciente. Entonces, tenemos un paciente con una constipación crónica refractaria, sin respuesta a los laxantes osmóticos ni estimulantes, con una manometría anorrectal que descarta Hirschsprung, en este caso, sin biopsia, y no demuestra disinergia, y un tránsito con marcadores poco evaluable, pero que impresiona una obstrucción del tracto de salida. ¿Qué harían ustedes? ¿O qué haríamos en este tipo de paciente? Votos. ¿Alguien más? ¿Alguna otra respuesta?
But you just said that the girl was clean, or the boy was clean using animals. Is that your conclusion?
No, todavía, o sea, en ese momento, eso es como todo el trayecto terapéutico que tenía el niño previamente, que no había tenido, o sea, muy buena respuesta, pero que solo con los enemas se sentía que estaba limpio.
Él solo hacía estas enemas de fosfato cada 5 o 6 días y con esa, durante toda la semana estaba limpio, hacía ese enema, tenía deposiciones abundantes, blandas, no eran deposiciones duras y lo habían tomado como su tratamiento habitual. Cada 6 días un enema de fosfato. Y eso lo mantenía limpio y logrando deposiciones una vez a la semana.
Okay, so in this case, what we would do, so we would discuss it in our team because the X-rays are impressive, and the surgeon is he's nervous, he wants to do something. But our surgeon will always ask us, is the transanal irrigation, how does it go? Is it perfect? Is it imperfect? How many times a week do you do this? Do you do this daily? For how long? Did you do it for 1 week, 2 weeks, 3 weeks, a year? And nowadays, we want to show the parents and the patient that they should do it for at least 6 months, every single day, without stopping. Because if the child in this case is clean and has no problems, but has an artificial defecation with the transanal irrigation, surgical will hold his hands on his back. Okay? And then sometimes we want to see this in clinic, as I told you, because the parents insist to ask the surgeon to remove the colon because it's elongated, it's distended. As you heard me speaking, we have such a high complication rate of surgery, all kinds of misery. And of course, we have very good patients, but you never can predict which patient is really good. That's why we want to have them in the hospital for a week, let the nurses do the irrigation every day. And if he's completely clean, has no abdominal pain, that's it. They go home and we wait and see what's happening.
Igual vamos a ver en la siguiente diapositiva lo que pasó con el paciente. Para que vean las irrigaciones transanales. No, sí, era que el paciente todavía no llegaba a la necesidad de vigilarlo porque tuvo una buena respuesta. Okay. Siguiente. Entonces, ¿qué hicimos? Entonces, iniciamos las irrigaciones transanales, se le hizo previamente el entrenamiento al paciente en cuanto al tratamiento e inició el tratamiento con una buena respuesta. Actualmente el paciente tiene 3 irrigaciones por semana, logra las deposiciones abundantes y no se mancha, y aparte de eso realiza el procedimiento por sí solo, o sea, de forma independiente, y tiene una reincorporación en su parte social, que es lo más importante también, de que el niño se reincorpore sin tener ningún tipo de dificultad.
No, sí, ¿por qué decidieron hacer directamente las irrigaciones? En mi experiencia, el equipo funcional es muy reticente a cualquier proceso invasivo de irrigaciones transanales de 3 veces por semana, ni hablar. O sea, de una, ¿y por qué no fueron con el botox o con una biopsia de lino o alguna otra cosa que vaya más a la resolución del trastorno obstructivo, incluso continuar con el testigo?
No, lo que nosotros vimos es que son reticentes a las irrigaciones transanales los pacientes que no han experimentado enemas previos. Los pacientes que tienen experiencia con enemas, cuando uno propone las irrigaciones transanales, tienen buena aceptación. Aceptan porque pueden hacérselas solos en el baño, nadie los mira, y sobre todo cuando se dan cuenta que están limpios, y entonces que ha sido un tratamiento menos invasivo que otras propuestas. No avanzamos con el botox porque en la manometría el paciente no tenía presiones elevadas, se relajaba en el pujo. No sabemos qué pasa cuando está en su casa, pero en los estudios acá relajó, expulsó el balón, la presión era normal en el esfínter, pudo hacer con fisioterapia peliana mientras lo hacía, tuvo deposiciones espontáneas en su casa, pero bueno, no pudieron continuar el tratamiento. Entonces nada es como que nos hacía pensar que en este momento la primera propuesta iba a ser quirúrgica si ellos aceptaban las irrigaciones transanales. Las hacen 3 veces por semana porque estamos empezando, no hace mucho que tiene el sistema y queremos controlar a ver cuánto es que lo necesita para no seguir dilatando y elongando ese colon que ya lo tiene así. Entonces dijimos, bueno, vamos a ver en principio con enemas más seguidas y veremos en el tiempo si puede hacérsela menos veces, pero por ahora solo tiene deposiciones con la irrigación. Sin irrigación, el día que no irriga, no tiene deposición.
Un tratamiento combinado.
No, solo la irrigación.
Buen día. Lo que yo no entendí es por qué se habla de una obstrucción a la salida, al tracto de salida. ¿En qué se apoya para afirmar que está obstruido?
Hablamos de una obstrucción al tracto de salida funcional.
Oh.
Entonces, en la obstrucción al tracto de salida funcional intervienen varios componentes del mecanismo defecatorio, desde el empuje rectal a la relajación anal y al empuje también de los músculos abdominoperineales. Si hay algo en ese mecanismo que falla y no permite que se elimine la materia fecal, nosotros hablamos de obstrucción al tracto de salida funcional. No estamos pensando en cuestiones mucho. Claro.
Bueno, buenos días, la verdad ha sido un gusto escuchar esta charla. Yo formo parte del equipo con mis compañeros de este hospital, soy cirujano. Me gustó mucho ver que la cirugía tiene algo que hacer en la constipación, pero es la última opción. El caso de este paciente que viendo un megarectosigma secundario a la constipación no necesitó la resección. Y creo que lo más importante es abordar al paciente con constipación refractaria, con un equipo, porque cuando este paciente llega al cirujano, el cirujano lo primero que piensa es en operarlo y sacarle eso que no funciona. El especialista gastroenterólogo, especialista en motilidad, tiene muchísimas herramientas que cuando el cirujano se encuentra solo no las tiene. Así que bueno, todos los casos que hemos visto estos días nos quieren decir que debemos trabajar en equipo. Y que la verdad creo que la cirugía, si bien es muy importante, es la última opción. Existen incluso los enemas anterógrados se están dejando de usar por el peristil. Ya casi no hacemos chai, no hacemos malón, y la verdad que los resultados que tenemos en los pacientes son muy buenos, muy parecidos a las encuestas que mostraron. Bueno, eso de la parte de...
Hola, no no sé si se pueden preguntar, pero la pregunta, ¿cuál fue la histología de la colectomía que usted presentó en la...
We didn't find anything, nada, de nada. It's terrible, that's a shame. It's a shame. I'm always disappointed because we see, we see so many patients and there's hardly anything you will find. So we send our biopsies most of the time to the UK because they describe in very important journals abnormalities nobody finds. And when we send our specimens, nothing. So we ask for cells of Cajal. But you know, the cells of Cajal are very difficult because it depends on how the pathologist looks at the slides. And it's sometimes they say, oh, there's a lack of cells of, oh, there is a decrease of number of cells of Cajal. But it really depends on how they cut the biopsy. So I find it really difficult and very disappointing that in many of these children you find nothing.
Con respecto a los lavados anterógrados, entendí que su indicación es una serie de fracasos clínicos y terapéuticos previos, no la manometría colónica, quedó claro. Sin embargo, está descrito que las ondas de alta presión, las high ambient pressure, vuelven al colon luego de hacer lavados anterógrados. No entiendo la fisiopatología de la nueva contracción del colon, por qué se produce luego de los enemas. Nunca entendí por qué sucede, si no sucedía.
I don't know either. The only thing I want to say about the melon, so in the spina bifida, it's very, very efficient because there's no problem at all with the colon. The only thing that matters to us as pediatricians or pediatric gastroenterologists, so if they're not able to expel the rectal fluids, don't do the
that's a contraindication.
Yeah, for me, I don't think if Carlo Di Lorenzo will give the same talk, he might disagree with me because he says, well, in our hands it's successful. In our hands it's not successful. It's not because I don't believe him, but if you're not able to expel the material, then don't do it. And I even find it difficult in children with true slow transit constipation. I have this observation that it's working not that good either with the melon. But I never studied it, but this is my experience.
¿Una pregunta más?
Hoy que usás el polietilenglicol a cualquier edad, ¿a partir de qué edad usás el polietilenglicol? Nosotros habitualmente a partir de los 6 meses.
Day one. So most of the general pediatricians and neonatologists, they use lactulose, but polyethylene glycol is very safe. Very safe.
¿Descrito? Is it written?
Yeah, well, of course, there are no randomized controlled trials, but there is a systematic review which shows that in 500 children was studied, but the woman who was the queen of constipation in the old days, Vera Lullingborg, she was working in the US, but she was originally from Germany. She has a paper on babies and polyethylene glycol, and at that time it already worked well, without any side effects.
Okay. Una última pregunta. Nosotros lo que hacemos es neuroestimulación sacra percutánea. Recién estamos empezando con el protocolo. ¿Tenés experiencia en eso?
No. But there are good data now from Australia, of course, because they started it, and from Iran. Yes. Yes.
Una pregunta más.
Doctor Benninga, muchas gracias por su exposición. Yo soy urologo pediatra de acá del Hospital Garrahan y en ninguna de la exposición se hizo referencia a las consecuencias de tener un tracto digestivo con constipación o con incontinencia fecal en la repercusión de la vía urinaria. en la incontinencia urinaria o en la dilatación de la vía urinaria. Entonces mi pregunta es, ¿con qué frecuencia los pacientes que reciben en su centro vienen referidos desde el urólogo como primer paso y después van al gastroenterólogo? Porque ese flujo, ese camino es muy frecuente en nuestro medio, tanto en el hospital público como también en nuestra práctica privada, en neurogénicos y en pacientes no neurogénicos.
Okay, thank you for your question. You know, I can talk about constipation for days, for weeks. And one part is on urology and constipation, but you know, I have to go to a soccer match tonight, so I can't discuss everything. And there is, of course, there's a very big association between the gastroenterologists and urologists. That's a fact of life, because we work closely together with the urologist. There is a debate on how to use the ultrasound, because I don't believe in it. You believe in it, that you can make the diagnosis. You can diagnose constipation based on the rectal diameter, and there are no good data. We currently doing a systematic review, so we hope to use the ultrasound in the future, but we only did a study where we used our finger and compared it with the ultrasound, and then if the rectum was packed, and the ultrasound indeed showed that you have a impacted rectum with feces. So that's why we think you should use the ultrasound only in those children, not to diagnose constipation. So if they are really afraid of the finger, you can ask the urologist or the ultrasound expert to look at the rectum. But in children with constipation, 25% of the children have urinary tract infection or are incontinent for urine. In the children I discussed yesterday with non-retentive fecal incontinence, it's even higher. So these children have no constipation, but only fecal incontinence. And in those cases, it's like 50% of the children also have urinary problems. And we think that they neglect their urge to go to the toilet. It's a behavior problem and not a physical problem, very difficult to treat. In the Netherlands, I don't know if you do it the same, but we first treat the constipation and then ask the urologist to help us if the urinary incontinence doesn't disappear because of the association between the rectum and the bladder. Are you happy?
Bueno, nosotros estamos muy contentos de haber contado con su presencia esta mañana y bueno, con la compañía de todos ustedes, les agradecemos a todos una vez más